مهمة، أرجو أنه تدققوا فيها جيدا وتستمتعوا فيها، لأنه الآن it is firing. دخلت في ميشن is there something we call hypertension, resistant hypertension or not. حتى احنا على اتصال مع الجمعية الأوروبية لأمراض ضغط الدم، وعلى اتصال مع الجمعية الأمريكية لأمراض ضغط الدم بصراحة عشان نغير الترم في التكست بوكس. بدون جدال high blood pressure is the killer. It's the killer number one. Everybody knows that. وما في داعي اني اضيف اكثر من انه تسبق كل الامراض الاخرى. And controlling it is definitely one of the most cost-effective methods of reducing premature cardiovascular mortality and morbidity. Well, control worldwide, as you all know, is lousy. It is really يعني مخجل بشكل shameful انه till now we are not controlling blood pressure in a good shape or in a good term. So even in Europe or in every country in the world, the control rate is really diminished below 30%. So it remains inadequately diagnosed and treated and definitely poorly treated. كل الجايدلاينز الآن أصبحت واضحة for everybody. Blood pressure must be 120 over 80, normal 120 to 129, and the diastolic is up to 84. وفي الجريد 1 و 2 و 3 وصار في stage 1 و stage 2. So let's go through hypertension. Resistant hypertension as a term أنا ضده. ودخلنا في debates, a lot of debates about resistant hypertension. Is it resistant hypertension or resistant patient or resistant doctor or certain factors interfering with controlling the blood pressure? أنا الحقيقة مع الترم الثاني اللي هو بيتكلم عن hard to treat. So resistant كان الكلام أو التعريف اللي كلنا درسناه. أنا كنت بالسبعينات في بغداد وتخرجت وسافرت على بريطانيا مباشرة، وكان الترم موجود وصار زاد أكثر في آخر 20-30 سنة بداية القرن، وكان resistant hypertension. We cannot control hypertension. أنا مع إنه في شيء اسمه hard to treat or we don't have proper management to treating. في demographic في factors معينة زي الجندر أو الage أو السموكينج، وطبعا احنا بندخل في comorbidities like diabetes, like renal disease and others. كلها هذه interfering with proper management of hypertension. Let's start with lifestyle barriers. First lifestyle barrier, أغلب أهلنا, most of them, they are taking a lot of salt in their food. مجرد إنه ننزل salt intake, just reducing the salt intake بنزل لي الضغط systolic 20 millimeter mercury, diastolic 10 millimeter mercury, down to مجرد salt intake. وحتى طبعا alcohol consumption is not an issue in our countries. Obesity definitely, sedentary lifestyle. So the first thing, address the lifestyle barriers to blood pressure control. زي ما حكيت just simple trial تحكي انه مجرد خففنا السولت بعض مرضانا، انه بس تقول له رجاء خفف السولت. Please reduce the amount of salt in your intake in your food. And he says, no, come on, I'm taking just normal salt content. And it is not true. احنا عم ناخد حتى خبزنا بملح كثير، حتى الخبز تاعنا فيه ملح كثير. ولهذا السبب أنا مع إنه نضلنا addressing the story of salt intake. الأدوية, most of them, a lot of our patients having arthritis, having asthma, having the oral contraceptives اللي هي في كل العالم الآن بحاربها. Most of them, they are telling you, please try to discontinue or minimize as you can the non-steroidals, the sympathetic. هاي ما بتضوي يمكن. No. Sympathomimetic drugs, الهيربلز. احنا بلاد بنشتغل كثير بالهيربز، كثير أعشاب وغير أعشاب وإلى آخره، وبنلاحظ إنه a lot of our people taking it liberally without any control. The anabolics, the appetite suppressants, the oral contraceptives, all of them. So addressing the interfering substances is crucial for the management of hypertension. And take the adherence. The story in adherence is really يعني a catastrophe. Most of our patients بيعدوا أدويتهم بيجيك ماسك كيس. He is taking his tablets and please try to reduce the amount of tablets I'm taking. That's why there is a lot of combination therapies. That this is number one. Number two, he says, yes, I am taking my medicine. لما تعمل check لإلها بتكتشف إنه 1/3 of them are taking their medications properly, 2/3 are not. وبعضهم لما بتعمل studies in the urine and studies in the blood, you can find very well that there is no trace for the medicine in the urine or in the blood. So the adherence issue is an issue. Please concentrate about taking their medicine properly. حتى لما كنا نبعث للريجسترد نيرس كانت بعضهم يقيس والى اخره ويقعد يحكوا وياه يقول والله انا تركت الدواء اول يوم ثاني يوم رجعت له وهكذا. فاذا الادهرنس is an issue. وهاي الكومبليت نون ادهرنس والبارشال نون ادهرنس is a worldwide story and they are talking a lot about. Talking about white coat and about pseudo resistant hypertension or truly resistant hypertension and going to secondary hypertension, yes, there is a term of secondary hypertension, not resistant hypertension, and of course the adherence and the non-adherence definitely بتحتاج كل جهودكم كأطباء وكنurses وكstudents, everybody to talk about it. هاي therapeutic drug monitoring facilities وكانت بتحكي عن موضوع الادهرنس a lot. هلا diuretics, we have a problem طالما احنا we have a lot of salt intake, we have a lot of salt intake and water intake, في عنا مشكلة diuretics. Sometimes the diuretics اللي تؤخذ are not sufficient. We need to give the proper dosage of diuretics. 12.5 sometimes is not enough for hydrochlorothiazide. You need 25 milligrams or other diuretics. That's why we need to optimize the medicine and the drugs and the doses. وكلها كانت تحكي إنه higher doses may be associated with some side effects, metabolic effects, but sometimes we need it and we can control it and we can take care of our patients better with a good dose. Spironolactone, it is not used بشكل كبير. احنا يمكن ككارديولوجيست we use it a lot for heart failure. MRAs, one of the fantastic four in management of heart failure. Nowadays رجعت صعدت. اعتقد انه مشكلة السبيرونولكتون زمان كانت شغلتين. The first thing was انه رخيص. It's cheap. فيبدو انه تجاريا لبعض الشركات ما كانت تشتغل على موضوع السبيرونولكتون. Second issue يمكن اخواننا nephrologists بيقول لك انه sometimes it has its own side effects, of course. So we need to monitor our patients when you are talking about so-called resistant hypertension, and I prefer the term hard to treat. It is a resistant patient or a resistant doctor. We need to give a certain good diuretic for that. Practice tips here. Sometimes the physician must stop the whole regimen and start from the very beginning to give a proper medication protocol so that our patients can be well controlled. يعني مرات ما تبدل له حبة وحبتين، مرات انت مضطر تنسف كل البرنامج عشان الرجل يرتاح ويقول لك ايه اوكي هسا أنا بديت أحس بالراحة، لأنه في موضوع psychological sometimes is there, or sometimes we need to put our patient in a hospital. So consider referral to a specialist when we find some problems. يمكن we go into intervention with renal, with others. أجهزة معينة نستخدمها. هذه في نهاية المطاف again إحنا بنتكلم قاعدين في إشي اسمه modifiable risk factors. هل تصدقوا قديش؟ وانتم اكيد من غير ما اكيد مصدقين انه a lot of our patients smokers when they stop smoking their blood pressure goes down. صح ولا لا؟ blood pressure 1, salt intake 2, and sedentary life, obesity A lot of our patients taking combination therapy, and when they lose 10 kilograms of their weight, the blood pressure will go down. So it is, again, it is not resistant hypertension. It is a failure to treat this guy. We are the losers, and the patient is a loser because we couldn't address the main problems he is facing: his obesity, sleep apnea. A lot of patients having sleep apnea, when they are treated with CPAP or BiPAP or others, the blood pressure goes down. So we have risk factors and we need to take care of them. Non-adherence, again, is a story, and don't ask your patients, please, whether he is taking or not. Maybe you can give it in a soft way. I think you missed a tablet, you missed 2-3 tablets that week, because when you tell him you are not taking your medicine properly, he will take a defensive position and he says, no, I'm taking it. You are the failure, doctor, not me. This is the story. So I think it's a failure in both ways. In the doctor way, in targeting the patient, and in the patient who is not taking his medicine properly. So the cardiovascular renal continuum, you know that managing hypertension and the renal story, I think it is 20 minutes or 10, because they told me 10 minutes. Yeah, I can proceed. So, microalbuminuria, macro, nephrotic, all this can be controlled with a combination therapy, and definitely the initial combination, don't be reluctant to give combination. Don't be reluctant to give combination in a single pill, fixed dose pill, because it is an excellent way to manage this patient and to minimize the side effects and to prolong his life. So, secondary, everybody knows we have certain problems like renal parenchymal, renovascular, aldosteronism, sleep apnea, as I just mentioned, drugs, and pheochromocytoma, Cushing's, hyperthyroidism. All these issues, they are under the category of secondary hypertension, not resistant. So again, if we can treat them, definitely the patient will be treated. So it will not be resistant anymore. Resistant hypertension, as a term, I'm against it. I'm with the story of giving the patient, yes, he is giving us hard time, it is hard to treat, it is difficult, there are interfering issues in treating the hypertension, but definitely not resistant. As I just mentioned, overweight, smoking, all these issues are important, and definitely this is, in short, my what is called resistant hypertension. Confirm the treatment resistance, pseudo-resistance is there, identify and reverse the lifestyle factors, discontinue the interfering substances, and definitely the summary, we can treat, this is a complex, it's a phenomena, it's a complex, it's a problem, but it needs a lot of effort to identify the problem and to tackle it and manage it properly, and thank you very much.